Hello, my name is Michael Cecchini. I'm an associate professor of medicine at the Yale School of Medicine. I'm a medical oncologist in the Yale Cancer Center. I'm co-director of the colorectal cancer program and co-director of the GI clinical research team here at Yale. Um, I'm here with my colleague, Dr. Pantel, one of our colorectal surgeons. I'll let him introduce himself.
Thank you, Mike. My name's Haddon Pantel. I'm a colorectal surgeon also here at Yale. And I just want to thank everyone for taking time this evening to hopefully learn some helpful things about colon cancer and rectal cancer.
So we'll be doing the Yale CME for colorectal cancer for 2024, 2025. Originally, this was going to be a three-part session with myself, Dr. Jacqueline Gaddy, and Dr. Pantel, but this will be just the two of us, Dr. Pantel and myself, this evening. We're going to start with my presentation. Dr. Pantel will moderate some questions, and then the role will reverse. He'll present, and I'll moderate some questions for him. Um, we'll have no more than a max of an hour presentation, which will therefore give plenty of time for questions. This session will certainly not go any longer than 1.5 hours. But we'll frankly probably be more along the hour mark. Please put your questions in through the chat. Some questions may be answered directly by response in the chat, but we'll try and field the questions to the presenter. If the question seems pertinent at the time of presentation, you may see Dr. Pantel and myself interrupt each other to answer the relevant question at that time. Otherwise, we'll probably save some of these questions for the end of the presentation. So thank you so much. Let me get my presentation up right here. All right. So, again, this is our 2024-2025 Yale CME for colorectal cancer, and thank you so much for joining us this evening. Here are my disclosures, and here's an outline for what I'm going to talk about today. So,
We
in the
still, we
CME,
still,
I'm really going to,
can you guys, I think your slides need to be pulled up.
oh, I'm sorry, I'm not sharing him. Good call there, Ed. That better?
That looks perfect.
All right, let's just back up there. Wouldn't be a presentation without a few technical difficulties, and I'm not the chief technology officer here or anything. So, so this is the 2024-2025 Yale CME for colorectal cancer. My disclosures again. And here's an outline for what I'm going to discuss this evening. I'm going to talk about biomarker updates from the past year. I'm going to talk about BRAF V600E, obviously a very important biomarker for our disease, and some updates in that treatment. KRAS and HER2, we've got some updates there as well. Some approvals in the last year with these biomarkers. We'll talk about mismatch repair deficient, microsatellite instability, high disease. It's always a very important topic, and we have some very recent updates that I think are important. We have updates in ctDNA with a 5-year follow-up from the dynamic study. We have the Altair results that tell us a little bit about what we can and can't do, perhaps with persistently positive circulating tumor DNA. We have a recent approval for anal cancer with retinifimab that we'll be discussing as well. Not approval. We have a recent new guideline change for retinifimab. So how do we apply the biomarkers in 2025 for colorectal cancer? These are the biomarkers really that, as I see them at this point in time, we have KRAS, which is sort of a negative biomarker for most patients in the first line setting. What we can't use drugs like panitumumab and cetuximab. We have KRAS G12C, our one actionable KRAS mutation that we can target with drugs. I'll come back to BRAF in a second. We have some rare fusions. Of course, we have TMB high, which is relatively rare, but microsatellite instability high, and we have HER2 amplified, maybe 4% of these patients, 4%, 5%, each of these. So again, we've done a good job, I think, over the last several decades of carving up this type of cancer into different molecular subtypes. But there's a lot of work to do in this maroon color, which has no biomarker, and the blue color, we're still not able to really target most of these variants of KRAS. Although that really may be changing with some of the new pan-RAS inhibitors that we have in the clinic, which I could really think could change dramatically how we think about this disease. But what about this subtype, the BRAF V600E, 9% of metastatic colorectal cancer, one of the most aggressive molecular subtypes of the drug, of the disease? We've used encorafenib, a BRAF inhibitor with cetuximab, as second-line therapy for several years, since that was published in the New England Journal of Medicine as second-line therapy. But first-line therapy has largely been chemotherapy, FOLFOX, FOLFIRINOX, plus appropriate biologic, which would generally be bevacizumab. What about moving things up to an earlier line? So that is what the Breakwater study tried to do. This was just presented two months ago at our on our meeting ASCO GI. This is a practice changing study. So this took patients that were of appropriate age, had measurable disease, had never received any prior treatment for their metastatic disease, and of course had BRAF V600E mutations, a class 1 mutation in BRAF, the BRAF protein functioning as a monomer to stimulate tumor growth as an oncogene. And randomized patients in a 1-to-1-to-1 fashion for encorafenib and cetuximab, BRAF inhibitor and cetuximab, BRAF inhibitor plus cetuximab plus chemo plus FOLFOX6 versus standard of care options, FOLFOX, FOLFIRINOX, etc. This arm, encorafenib cetuximab, you can see that numerically is smaller, and that's because it closed earlier. And these are really the arms that move forward for comparison here. The study was looking at progression-free survival and overall response rate as a dual primary endpoint by BICR, by blinded review. And of course, overall survival is a key secondary endpoint, which will kick in automatically depending on the response rate seen. So this is the way that they built their study. Again, dual primary endpoints. If the overall response rate was significant, then OS would be triggered for an interim analysis. And as we'll get to, this is exactly what happened given the higher response rate. This was a balanced study. Again, chemotherapy plus encorafenib cetuximab versus standard of care. Most of these patients had right-sided tumors, which is what we would expect for this disease. Certainly a worse prognosis for this this subtype of colorectal cancer, and frankly, the worst molecular subtype in terms of prognosis. 2/3 of patients, or more or less, had liver metastases in this study, and again, were quite advanced overall. This is the response rate that we saw, so 60.9%, so 61% essentially, with this FOLFOX and encorafenib cetuximab versus 40% with the standard of care of chemotherapy alone. So certainly a substantial improvement in response rate. When we look at duration of response, also very impressive. More than 6 month duration of response, 46% with the investigational arm versus only 15% with the chemotherapy arm. So improving durability of these responses. Still have a ways to go, though, as you can see that at the year mark, this does drop back down to 15%. So that's great. It's important to get responses, but this is really what matters. Are we making when we intensify chemotherapy, are we just seeing responses, but survival is ending up the same? This was the overall survival that we saw. This is an interim analysis, and even though you see a very impressive hazard ratio, 0.47, and a low p-value at this interim analysis, it was very strict in terms of statistical design. This actually technically does not achieve statistical significance, but it is an interim analysis. Obviously, this is a very promising first step, and the response rate and it speaks for itself as well. And based on this, there was an approval granted for this in the frontline setting. When we look at the subgroup analysis, this is what we saw. So you can see this to the right of this line favors the encorafenib cetuximab with FOLFOX. So another way of putting it is basically all subgroups seem to benefit from this. And where does this land? Even though this was just presented in January, we've already got it now into our national guidelines. So for BRAF V600E mutation positive encorafenib with appropriate biologic, which would be an EGFR inhibitor plus FOLFOX, has become the standard of care. Of course, there may be patients you think can't tolerate this, and those patients could still get FOLFOX if they had some contraindication to encorafenib or cetuximab or panitumumab or something like that. But I do think the majority of patients will be getting this regimen going forward. So that was BRAF V600E, this slice of the pie. What other slices of this pie have we made an impact on in the last year? So KRAS G12C has certainly been an evolving story over the last few years, but were two approvals with KRAS G12C in the last year that I want to highlight. Adagrasib, KRAS G12C inhibitor, and sotorasib were both granted FDA approval for advanced CRC this past year. These have been in guidelines for a little bit. Many of us may have been familiar with their use from managing lung cancer, but now a full FDA approval for sotorasib, and again, accelerated approval for adagrasib. Both of those agents available. I think this is a very important breakthrough in the management of colorectal cancer is targeting these molecular subtypes. Again, personalized medicine, getting the right drug to the right patient at the right time. So this is some data from the sotorasib study. You can see here that sotorasib and panitumumab was better than standard of care for advanced patients. Again, this is advanced patients. There are studies going on to move this therapy up into an earlier line of therapy. When we look at the median progression-free survival for advanced patients that have progressed on 5-fluoropyrimidine, oxaliplatin, or irinotecan, et cetera, the median progression-free survival with the standard of care arm was 2 months. That's the time of a scan, right? That's the time of a scan. We scan every 8 weeks. So basically, standard of care doing very little for these patients, whereas the investigational arm had a PFS of 5.62 months. I think we still have a ways to go to prolong that. Moreover, I think moving these drugs up earlier on in the line of treatment, which is under active investigation, will make a better impact. Giving these drugs earlier in somebody's treatment course, I think, will get more effectiveness from them. But certainly, this now is a reasonable option for our patients, essentially in the third line setting, or I prefer the term 5-fluoropyrimidine refractory setting. So some of the data from adagrasib, the other G12C inhibitor, you can see this was from the New England Journal paper that supported its approval. You can see in this waterfall plot, the majority of these bars going down, indicating cytoreduction, and about half of them crossing the 30% threshold of partial response. You can see, again, similar PFS, similar OS for a very advanced patient population. So I think these numbers can only improve as we make these options available earlier in the course of treatment for our patients, which hopefully future studies will show. So what did we also see? We also saw in our NCCN guidelines that KRAS G12C mutation positive patients should be receiving sotorasib or adagrasib with appropriate biologic therapy, EGFR inhibitor. Either could be appropriate. What about HER2/neu? We saw some updates at ASCO in June of this past year from the Mountaineer study. This is actually the final update from this study. I'll just highlight it in a couple of slides because, again, it is speaking to this theme of biomarker, of these rare biomarkers for colorectal cancer that are highly actionable. So this was a study that evaluated patients that were essentially on their third line of treatment for colorectal cancer. So again, prior 5-fluoropyrimidine refractory essentially here. Then we're getting a small molecule tucatinib with the antibody trastuzumab targeting HER2. And this was really the arm that was investigated. You can see 41 plus 45 in over 80 patients. Per FDA requirements, they were required to look at tucatinib monotherapy to really determine separation of components. But these were the arms that biologically really made the most sense, frankly, and were used as the main efficacy analysis to look at the effectiveness of the drug. So what were the final outcomes from the study? We can see here that Dr. Strickler presented this at ASCO in June, a response rate of 39%, so close to 40% response rate. Durable responses, 15.2 months, median progression-free survival, 8.1 months, median overall survival, 24 months. This is for patients in the third line setting. These are numbers that we would typically expect to see in the first line setting. So very promising targeted therapy for patients. Main side effect of the combination being diarrhea to watch out for. But overall, felt to be a good alternative to the chemotherapy options these patients have in these later lines. Whether or not this will translate to moving it up earlier is being evaluated in additional studies, including first line study now. Um, but this has now become the really the standard of care for HER2 positive disease in the refractory setting. One other very important biomarker is mismatch repair deficiency, and this is a biomarker that comes up very regularly in our conferences and very regularly in my discussions with patients because of the impact immunotherapy can have on these patients, which we've known, right? We've known Keynote 177, immunotherapy is better than chemotherapy. Pembrolizumab in blue here, showing a prolonged progression-free survival compared to chemotherapy. The immune checkpoint inhibitors like pembrolizumab, nivolumab, ipilimumab have been used in the refractory setting for some time, but moving them up into the first line was what Keynote 177 did for the first time, and it showed an impressive PFS benefit. Because of their use later, the OS benefit has not been shown or reported yet, and I think will likely take a long time to see that. Hazard ratio, so pembrolizumab pretty much work better in all subtypes. But what's new? What's new is Checkmate 8HW. This is a story that has been evolving for a couple of years for this trial because it's a three-arm trial. And what did we see first? We saw the Nivo arm presented, and now what we're seeing is the Nivo Ipi arm versus chemotherapy. At first, we saw the Nivo Ipi arm versus chemotherapy, excuse me, and then now we're seeing Nivo versus Ipi Nivo, which was really the comparison we wanted to see the whole time. We already knew that immunotherapy should beat out chemotherapy from Keynote 177. So we saw this last at GI ASCO. So this is important data to have, but in many ways this isn't necessarily changing the paradigm completely. So this was Ipi-Nivo, dual immune checkpoint blockade versus nivolumab, versus chemotherapy alone. And you can see very big separation of these curves here, not even reached median progression-free survival. Very impressive durability. Ipi-Nivo clearly outperforming chemotherapy here. But again, what we need to see is two immune checkpoint inhibitors really better than one because it could be potentially more toxic. So that's what we got to see this year at GI ASCO in 2025. We saw Nivo Ipi versus Ipi. This is first line therapy for mismatch repair deficient tumors. Moreover, central confirmation was done for mismatch repair status, which is really important, and wasn't done in Keynote 177. So Ipi-Nivo did, though, demonstrate improved PFS compared to nivolumab. This was simultaneously published in the Lancet, so this is the reference from the Lancet. If we look at the central confirmation of microsatellite instability high, where we can be darn certain that the tumor is truly mismatch repair deficient, this is the kind of separation we see here. So again, chemotherapy, those curves were down here, but we are seeing very clear separation that Ipi-Nivo has an improved PFS. You can see highly statistically significant hazard ratio 62. In the whole, not only centrally confirmed subset of patients, it's very similar numbers. So it does seem that Ipi-Nivo is better than nivolumab. What about in the subgroup analysis? When we look just about all subgroups, were favored using the dual immune checkpoint blockade. What about response rate? Well, if we just look at the number of overall response rate, you see it's 71 versus 58% with two immune checkpoint inhibitors versus one immune checkpoint inhibitors. Notably, this is way higher response rate than we saw with in Keynote 177 with pembrolizumab. Again, that may have some things to do with the central confirmation, mismatch repair status testing, or there could be other reasons for that. So higher response rate, better progression-free survival. What about toxicities? Not unexpected to see more toxicities with dual immune checkpoint blockade. With the dose of Ipi we use now, certainly these are much more manageable. When you just look at the totality of grade 3 adverse events, 22 versus 14%, is different, but is not dramatically different. And I think many of these we've become able to manage effectively. But frankly, there are some patients that will be left with lifelong endocrine disorders, and that needs to be taken into account. So at the end of the day, though, I think ipi/nivo is become standard of care for a lot of patients with first line mismatch repair deficient tumors. I think for patients that you're more worried about toxicities or that have lower burdens of disease, it's not unreasonable to think about the single agent anti-PD-1 if you're concerned about toxicity. But ipi/nivo is what I'm using in the majority of my practice for patients first line with this disease now, given that very dramatic durability of the curve. So, what's my summary for the approach to biomarkers in 2025? BRAF V600E, what changed? Well, what changed is now we use FOLFOX and encorafenib cetuximab as first line. KRAS G12C, what changed? Well, now we have these approved. Now they're FDA approved. There's not just data, there's approval behind them. So for fluoropyrimidine refractory CRC with the appropriate EGFR inhibitor given alongside, whether or not we get to start considering that in the first line setting will depend on how some of these other trials read out. Tucatinib and trastuzumab is the only HER2-directed therapy FDA approved um, for HER2-positive colorectal cancer, although there are other agents, trastuzumab, pertuzumab, lapatinib, trastuzumab, DS8201A, that can be considered considered as well. But this is the FDA-approved regimen. This is what I use in the majority of my patients as the first HER2-directed therapy. Although trastuzumab deruxtecan, yeah, it's certainly something I use if there's a KRAS mutation present, or if in addition to the HER2, or if patients are tucatinib trastuzumab refractory. And then now, what changed with deficient mismatch repair? I think ipilimumab and nivolumab as first line therapy has become my standard, except in circumstances where I think that toxicity is my major concern, and maybe disease burden is lower. So I'm going to pivot now to localized disease. I'm not going to talk as much about localized disease and the management around the perioperative setting, but I'm going to talk about what we do with some of the biomarkers for adjuvant therapy. So we've seen the dynamic study presented at ASCO a couple of times. It's been published in the New England Journal of Medicine initially at the 2-year mark, and then now this is the 5-year follow-up from the dynamic study. And so the dynamic study sought to evaluate patients with stage 2 colorectal cancer and evaluated for the presence or absence of circulating tumor DNA. And if patients had positive circulating tumor DNA, they were deemed high risk and given adjuvant therapy. And if patients didn't have circulating tumor DNA, then they were not so given therapy. So this is the kind of the breakdown of patients, and adjuvant therapy could be, by the way, it could be, well, I guess we have it here. It could be just oxaliplatin, just fluoropyrimidine, or it could be oxaliplatin-based chemo. When you look at these numbers, they look low because why? The majority of patients that you test for ctDNA will be negative, even the ones that relapse. About 20% of these patients were mismatch repair deficient. And again, you can see very few, 15-ish% were T4 disease. So the majority of these patients would be T3 and 0, so earlier stage 2 tumors. And what do we see? We saw, well, look, if you look at the ctDNA guided management versus the standard management, so in the blue line, if you're positive, you got adjuvant therapy. If you're negative, you didn't. And if you're in the red line, we did the standard management, so the typical histopathologic risk factors. You can see very little difference in overall survival, although arguably maybe 5-year overall survival is not even long enough for stage 2 disease. But what about when we start to look at cancer-specific survival? Again, not much difference. And look about recurrence-free survival. Again, not much difference with CT-guided management versus standard management. If not much different, then why use it? This was all predicated on trying to use less oxaliplatin, less neuropathy, less chemotherapy, less complications from chemotherapy with CT DNA-guided management. But I think that when you start to look at some of the details of the subgroups, it's important to know who this is a good strategy for and who this is not as good of a strategy for. So there are patients that are going to have high risk features that may be ctDNA negative. What should trump what? Should ctDNA negativity trump T4 status, other high risk histopathologic features? I would argue it should not trump T4 status, and this curve is part of my thinking on this. This is a similar curve that was presented in the 2-year follow-up as well. For patients that are CT that are negative, everybody on this slide here is ctDNA negative. But if you're T4, if you have a T4 tumor and you're negative, you still have a close to a 20% risk of recurrence. Um, and I don't think that's justifiable to kind of omit chemotherapy based on this alone. Again, this is an opportunity for shared decision making with patients. But I worry that the negative predictive value in T4 disease is not as good as it could be. This was another important piece of data, I think, that many of us were excited to see at GIASCO. Was, well, what else about ctDNA can we do differently in 2025? This was a study that took patients after chemotherapy, after the surgery, I guess first, and then after adjuvant chemotherapy, and it evaluated patients that were positive, either right after that chemotherapy finished or when they were minimally residual disease positive, when they had a ctDNA recurrence, and tried to say, can I cure more patients by giving additional systemic therapy? So patients had curative resection, could have been stage 4, could have been curative liver met resection, or it could have been a resection of that stage 2 tumor, stage 3 tumor. They got the chemotherapy for 3 months, 6 months, whatever it was, and then they got a ctDNA positive that could have been a 2 months later or 11 months later. If they had that positivity, they were randomized 1-to-1 to control arm of placebo versus experimental arm of trifluridine tipiracil, and followed for 3 years. And the main endpoint was looking at disease-free survival. And so what do we see? So this is, again, placebo in red, investigational arm in blue, a hazard ratio of 0.79 that was not statistically significant for disease-free survival, treating these persistently positive tumors with additional systemic therapy. When looking only at the patients with stage 4 disease, the hazard ratio was a bit better, and the p-value also a bit better. But certainly when looking at all patients, there didn't seem to be as much of a benefit. And again, this is disease-free survival, and you can see as time goes on, the curves do get closer and closer to, unfortunately, 0. So I think we're mostly just delaying recurrences in those settings rather than enhancing cure. So the summary, I think now for ctDNA, it's still incredibly prognostic in the adjuvant setting. For patients with T4 stage 2 colorectal cancer, to me, recurrence risk remains high even in the ctDNA negativity setting. So I would argue that the negative predictive value is not sufficient to recommend widespread use to omit therapy. Additional studies going on in that space, some of them here. We don't have really any data to support treating patients with persistently positive ctDNA after adjuvant therapy. So that's with additional systemic therapy. So for somebody that has minimally residual disease positivity, after chemotherapy, I would not recommend giving that patient additional chemotherapy. If there's a trial, that's one thing, but I wouldn't do it with any of the standard agents. And so I'm gonna finish with a quick discussion about anal cancer. So the podium study, I think that this is a very important study for a disease that has not seen as much development as we would like over the last decade. Evaluating patients with metastatic, so no prior treatment for metastatic disease, although they could have some neoadjuvant therapy, and then relapse with carboplatin plus rituximab, anti-PD-1, and versus placebo plus carboplatin. And the trial's primary endpoint was PFS, but also, of course, looking at overall survival. So it was a well designed study, very reasonable size. This is a hard study to do in this subtype of the disease, as many of these patients are cured, but those that are not cured have a very poor survival, and it's a rare cancer to begin with. Um, so we saw it was primarily a female population, primarily white. So that gives us some questions about generalizability. Um, and then patients, about a third of patients in both arms had metastatic disease. Very low rates of HIV positivity. Again, these are raising questions about generalizability. Most patients had some PD-L1 expression. So what did we see for progression-free survival? We saw 9.3 versus 7.4 months. So you see there is some separation of these curves here. This was statistically significant, a hazard ratio of 0.63. This looks great. Definitely suggests that retifanlimab is playing a role in the improvement here. And when we look at overall survival, you can see again 29.2 months with the immunotherapy added onto the carboplatin versus 23 months with the chemotherapy alone. Hazard ratio 0.7, p-value less than 0.05, although because this was an interim look um, at the overall survival, this doesn't technically meet statistical significance. But again, this is interim. I think many of us expect this to hold over time and gain statistical significance. Um, this made it as a category 2B, so a recommendation is first line therapy. I think when the overall survival data is mature, as long as it supports its use, I would expect this recommendation to become a bit firmer. But at the moment, it is a category 2B for first line therapy. So I'm going to end here. So I just wanted to quickly summarize and unpack some of the points we discussed. And BRAF V600E now has a new approval and a new strategy for first line treatment with FOLFOX and encorafenib and cetuximab, the standard of care for metastatic disease, as the initial therapy now. Ipilimumab and nivolumab should be considered, I think, for the majority of patients as initial therapy. Um, for mismatch repair deficient disease. Adagrasib cetuximab, sotorasib panitumumab, both acceptable regimens for refractory G12C mutated tumors. And I think while ctDNA is very promising, its negative predictive value is not sufficient for me to use it as a tool to omit adjuvant therapy for patients with PT4 disease, where recurrence rates still are around 20%. And I'm very encouraged by the data with retifanlimab. I'm looking forward to the overall survival, hopefully at a future Congress. I will stop here, and we can discuss any questions that Haddon you that have come through or that you want to
Sure.
ask, and then I will pass the baton over to you for your presentation.
All right, I'm going to start with an audience question, then I'll have my own. So, question from the audience first. They said amazing presentation. So agree completely. The question was, do you see any prospect of vaccines for treatment in colorectal cancer in the future?
Yeah, what a great question. So I as I mentioned, co-direct our colorectal cancer program and treat patients with standard of care treatments. But I also am a phase one investigator here at Yale. So I have been involved in a number of vaccine trials and certainly follow this literature. Um, I do think that the promise of vaccines is very solid. The problem thus far has really been how we've studied vaccine-based therapies. I think the paradigm of drug development has been to study drugs in the advanced setting first, make sure you see a signal, and then hopefully move them up earlier. But vaccines, I think, may be certainly different. And maybe arguably that should all be different. But vaccines, I think, we're probably not setting ourselves up for success in terms of their effectiveness in the treatment refractory setting where the immune system is a lot more dysfunctional, where tumor burden is very high probably as a rule for immunotherapy, but I think vaccines may be even more extreme example of that. And so we've seen data in pancreas cancer another cancer with arguably a very high unmet need like colorectal cancer, that a vaccine in the adjuvant setting when there was no visible cancer showed promise in a small subset of patients because that's all that was studied. And we've seen some of that data actually for colorectal cancer too. There's a Nature Medicine paper with a KRAS vaccine that I think looks promising for patients that had liver metastases resected, then didn't have any evidence of disease. So again, the authors of that study was published in I think it was Nature. It was one of the Nature journals. Looked at it in the minimal. The authors looked at it in the minimal residual disease setting, but after metastectomy, and they certainly showed impressive signals of potential success. And I hope that work will continue. So I do think there is a role for vaccines. I think we need to be smart about how we use them, and it's moving these types of therapies up earlier in the treatment paradigm, even for their early development. So yeah.
All right. Well, I completely agree with the previous person about great presentation. Um, in disclosure, I asked Dr. Cecchini, I said, "Do you have any questions you want me to ask?" He said, "No, I'm going to be on my toes." He'll be said to be ready for anything. So, there's a little bit about detail. I really liked what you talked about the dynamic study. You said that where did those T4 patients recur? I wonder if you think that the T4 patients were much more likely to recur as peritoneal-based disease as opposed to nodal or liver metastases, and maybe that's why circulating tumor DNA was not so effective in picking it up. Can you explain site-specific utility for ctDNA? Peritoneal versus more hematologic or lymphatic.
Yeah, no, that's a great question. I think unfortunately, we don't have the data from the paper. If it's in there, I would have to look in the supplementary for where the recurrence was, though. But you do bring up some good points. Well, so first of all, one of the points is unfortunately, T4 disease is incredibly prognostic. Obviously, lymph node status is too, but we know that stage 3A tumors have a better survival, frankly, than T4 tumors that are just stage 2. So that's a very important prognostic marker just for relapse anywhere. But as you point out, are there different areas of the body that recurrence is more likely to be detected by circulating tumor DNA? And the answer is certainly yes. Makes sense if there's hematogenous spread, a blood-based test may be better at picking that up. So peritoneal disease is a little bit of a blind spot, I would say, for circulating tumor DNA. Now, that does not mean you cannot have a positive result for peritoneal disease, but certainly it seems like you're less likely to have compared to a liver metastases or a lung metastases or something like that. I think liver metastases are probably the strongest correlation to having a positive ctDNA. All right. Well, please put your additional questions through the chat. We'll have some time for kind of both of us to answer them at the end. But now I'm going to pass the baton over to Dr. Haddon Pantel to do his presentation.
All right, tough act to follow. Hopefully, I think I'll be around the 20-minute mark, and we should be hopefully done around 7. So I'm going to just share my screen here. Let's see. All right, does that look okay just before I get started?
It does, yes.
Okay, all right. So thank everyone for your time this evening, and hopefully this just generates some questions and hopefully some answers as well. So I'm Haddon Pantel. I'm a colorectal surgeon here. These are my disclosures. Before I start into a little bit of the education part, I actually just want to start with a call to action. So as hopefully some of you guys know, March is Colorectal Cancer Awareness Month. And I've sort of started thinking about that a fair amount. I actually started thinking about this even back when I was a fellow. It's most people are probably aware October is Breast Cancer Awareness Month. I think one is a high prevalence of disease, but Breast Cancer Awareness Month has these very high profile public health campaigns supported by the NFL, Major League Baseball. There's a lot of industry and marketing tie-ins with pink ribbons and wearing pink and things like that. So it's been, a very highly visible public health awareness campaign. Um, how have we done? So 2001 is when March was designated as Colorectal Cancer Awareness Month. That was under Bill Clinton. And since that time, there's been a lot of things to raise awareness. I think there's a lot of things about it. Instead of pink, they picked blue. I'm not sure how blue is the colon, but unless we arrived at blue. Uh, and so there's been a lot of push to sort of promote our own month, and here we are. I think this event in itself is probably a sort of a tie-in from that, and so this kind of got me wondering: is this public campaign helpful? How does it do? Here's information from our own institution with our own Dr. Cecchini here, talking about one public interest, and then I sort of started wondering, well, we get people talking, but what do we do? I feel a lot of times in medicine, as a surgeon specifically, there's a lot of, writing notes and saying things and having conferences, but what are we actually doing for our patients? And that's really what I want this sort of call to action to be, and really sort of what got me wondering about this. So when whenever you have a question, what do? You Google it. This is a really interesting website. It's Google Trends. If anyone wants to look this up, they can. This is a screenshot from it last night. This is what people are looking at. So you can get pretty good data. This actually goes back quite far, and you can uses search terms, but also related search terms to build on like concepts and things like that. And so I looked at specifically colon cancer. This actually has data from the United States, but also I looked at data from the UK, or bowel cancer, and a bunch of other words. As you can see, we've got the search interest or popularity. It's a scale of 0 to 100. And then this is the data by month. And if you look at the blue squares, I use blue because blue is March for Colon Cancer Awareness Month. You can see here that there's these peaks. And actually, when we looked at this data, we fed it with a sinusoidal model looking at, is it quarterly? Is there a lag? Is it should the cycle be every 12 months? And in fact, this data does fit that model. So you do see a peak. I think you can see it just with your eye. I don't think you need the statistics behind it, but they are relevant to what's coming later. But I think you can see that if you look at, has March as colorectal cancer awareness month been successful? If you look at Google search data, whether it's perfect or not, I think the answer is yes. We've got people interested in this concept. But now, where I was talking about sort of the rubber meets the road, or the scope meets the patient, so to speak, how has that public interest been leveraged into actually improving upon screening? What have we done for our patients? So in order to sort of dive into that, the more functional end of things, utilize looking at rates of endoscopy across the United States, across a large endoscopy data set. This represents both community and academic centers, pretty much in every region in the United States. Um, and what we looked at specifically, because there's obviously variation, right? Some people take vacation in July and August. That's very common. Some people try and get a lot of scopes in December and November because they want to get things done or procedures done before the end of the year, when their before their deductible sort of resets. So what we decided to look at in this data set is how many endoscopists were scoping at that time, and what percentage of their colonoscopies were done for screening. The reason I mentioned about all that sinusoidal model and everything like that is I don't think you guys need the statistics here to see there is no peak. There is no annual increase in percentage of screening scopes done in this data set every March. And also we did try and fit the model and see, well, is there a shift or a delay, right? Because you may expect that you see someone wearing blue and you think, maybe I should get screened for colon cancer, and you get your Cologuard, and then certain time later, it comes back positive, and then you get scope. So this model does fit for that sort of time delay. We sort of set it in different frequencies or different cycles, and also shifting it back across basically every month. The bottom line is that really we don't see any effect for the impact on screening endoscopy. So, getting back to my original sort of call to action or call to arms for any healthcare providers or anyone who may be listening to this, either right now or just virtually later on at another date, when I think about what impact National Colon Cancer Awareness Month has had, I think we are being very successful in getting people, patients, interested or aware in what colon cancer is, what rectal cancer is. I think that is made aware by, sorry, that to me is evident by the search data. But where I think we as a healthcare community can do better for our patients is actually leveraging that awareness into something meaningful. And because from the endoscopy data, I don't think we're there yet. Because I'd hope to see some increase in rate of endoscopy or something moving forward. So my conclusion from all this, really, I think for us, we've done it. I said stop talking, start acting. I don't quite mean that. I think keep talking. Great. We've been successful there. But now I think it's things about start acting. So it's great to wear blue. It's great to have all these things. But I think there's other things we could be doing. Increasing access to endoscopy, things like opening our endoscopy suites on the weekend or focusing on other screening methods at that time of year to, potentially get things out. All right, I'm going to get off my soapbox and then hopefully talk about something else. So, I'm going to talk a little bit about the cyclic nature of something, and that's specifically about local excision of rectal cancer. I think a lot of times in medicine, we have these, we started one way, we changed, and we came back all the way around. I think of, I'm a surgeon, but I do endoscopy, I operate, so I think about bowel preps during colorectal surgery. It was initially nothing. Then it started with both antibiotic and mechanical prep. Then it went to just mechanical, nothing, mechanical, and lo and behold, we're back there to a Nichols-Condon prep, with antibiotics and mechanical prep. So I think a lot of things in medicine are cyclic as we get more and more data. And so I'm going to really be talking about that sort of cycle in regards to rectal cancer, specifically local excision. So we're going to start in the past. We're going to start around the 1300s. So this is around the 100-Year War. And this is John Arden. He was considered England's first surgeon. But the thing that's germane to this is that he is the first person to describe, or at least actually to write down, the diagnosis of rectal cancer. So back at this time, obviously there was a lot of infectious colitis, a lot of infectious problems. And so oftentimes it was hard to differentiate between dysentery or something else and a malignancy. And so he's the first person to really describe actually doing a rectal exam for the diagnosis. He said that you should on exam, you should find something hard as a stone. And so he was basically able to make that correlation that the blood, the mucus, the urgency was not all infectious etiology like dysentery, but was in fact a malignancy. So first diagnosis, then that's what we start at. I'm not sure they had gloves back then. This is I don't speak much Latin. Here's his original Latin text on this. So that was initial diagnosis. So we're going, 1300s, and now sort of where are we at now? I think most of us know sort of the initial treatment, CT, chest, abdomen, pelvis, are sort of rule out metastatic disease. And then for local staging, MRI pelvis with and without contrast. We also use ultrasound gel in the lumen, which can give you sort of, I have here what we call nice ability for bread slicing, making sure that as the slices of the MRI are coming through that we're being perpendicular to the rectum and that we're really able to get nice heights and measurements between the levator plate and the pelvic floor and the tumor. And so I think most of us know about our CT, our MRIs. Yes, I do think that there is still a place for endorectal ultrasound. It's obviously this is a picture actually out of our textbook. We as surgeons are still tested on this. These pictures still appear on our exams. But I do think it's also germane because I'm going to be talking about local excision and places where it should or maybe shouldn't be done or where we're going with it. And so I do think it's important to highlight that one of the advantages of endorectal ultrasound is having the probe directly on the mass can help differentiate between a T1 and a T tumor, and maybe help differentiate between who is a candidate for local excision and who's not. And then, of course, CEA, complete colonoscopy, but also digital rectal exams. So, yes, we have all of these tests and all of these highfalutin things, but we're still also going back to, the 1300s. And I do think it's very important to have a good exam. Um, if you're a surgeon or a radiation oncologist prior to treatment, is this fixed to the anorectal ring? Is this a T4 lesion involving the sphincters of the pelvic floor? What is the relationship like anterior to the posterior wall of the vagina or the prostate? So I do, MRI is excellent for things like that, but it's a single snapshot in time. So a dynamic physical exam can also give information, which I think is absolutely quintessential for the patient and for planning and treatment. Okay, so we've sort of talked about historical diagnosis, where we're at now, and then what about historical resection? And actually, when I initially made this slide, I said historical resection, and then I said historical local excision. And the thing is that at the time of the initial, so now we're 500 years later, it took 500 years from figuring out the diagnosis to now someone attempting to try and treat this. But really, local excision for the first about 50 to 100 years was really the only way of treatment. This is Jacques Frank who did the first excision in Paris. This was through a peritoneal approach. And really, it was only used for distal tumors. Essentially, the patient, this was done without anesthetic. The patient would bear down, they would do a pull through and a local excision. And really, that was the only option at that time. And as you can see, the outcomes were quite poor. Excuse me. Um, Very high operative mortality, um, and very high local recurrence rates too. I'm going to skip back from that. Sorry. Um, and really, a lot of the mortality was due to, again, they were not able to, if you entered the peritoneal cavity, that was considered a technical error in your operation, and then the patients usually would succumb to complications like peritonitis. So really, this is just operating or treating distal third tumors. So that's sort of the early stages of local excision. There were some people, so Liz Frank had a disciple who sort of advocated for resection of the coccyx and block for better exposure. And so there were some improvements for local excision. But really, things did not change much. This is a picture from our most recent textbook about what transanal excision was. So I have this recent history. Again, this is operating through an anoscope, showing an excision here and then a closure. So a little different from that picture, but actually probably not that much different. And our current recommendations, just like I was talking about before, are for really just favorable T1 cancers, really things that are just confined to the submucosa. Because, in this situation, you're not going to be sampling any mesorectal lymph nodes. And so anything that's going to put you at risk for that, whether it's lymphovascular invasion, poor differentiation, tumor budding, or something that's just technically challenging to excise, those are folks who, should be being considered for proctectomy. At least based on these recommendations. I'll talk to you a little bit. We're going to talk a little bit more about that, but I don't want to totally tip my hand. So here's the outcomes. This is a case series starting from 99 to 2003. The interesting thing about this is it does include some T2 disease, and you can see recurrence rates are quite high. Survival rates are lower. Some of this is a little bit selection bias because these T2 patients, we even not back then, but even at this time, people knew that probably should be doing proctectomy or TME. But so some of the selection bias, maybe the folks with a little larger or deeper tumors, maybe were less fit, and so were maybe more likely to undergo transanal excision. But you can see recurrence rates, like I said, high for these T2s and even for the T1s. Survival is low. And again, moving forward, I'm just trying to make sure we stay on time. I'm going to talk about, additional advances, right? Because like I said, this picture doesn't look that much different from that picture. So here we are now, I guess, in maybe in 2010. I consider that modern times, but maybe I'm getting old. Um, with using better visualization for transanal excision. So now we're talking about what's called TAMIS or transanal minimally invasive surgery. Um, Mike, can you see that? Is the video coming through?
Yes, it is.
Okay, good. All right, sorry. So you can see here, showing you some views now from, so this is the setup of the case, and then showing some views here for resection. You can see the visualization is much better. So we're able to clearly see the tumor, and we're able to clearly mark out a nice circumferential margin, and ensure. So a much different and better view from what we're saying. It is the same technique as was shown, or sorry, the same principle as was shown in those other slides, but maybe with easier technique and easier visualization. And then as you can see, I think I'm just going in circles. Here we go. You can see the same exact concepts of resection all the way through. You can see some fat here. But the visualization, you stop it when you get into bleeding, of course. And then I think one of the additional advantages is then ease of in-block and complete resection so that we can formally assess the depth of invasion. So which I think is one of the advantages of this type of technique is we can get a nice corked out, fully complete specimen, which is helpful for our pathologists. And then closure, which I do for hemostasis, excuse me, but you certainly do not have to do for TAMIS. Though, again, I do think it's helpful for closure and somewhat for symptoms. Okay, so I've been talking about local excision, all of this, but isn't this a little bit of ancient history, right? Aren't we still now even more modern? Aren't we into the paradigm of total neoadjuvant therapy and watch and wait, right? So when we talk about local excision, really it's just reserved for the patients with the earliest of disease with just favorable T1 tumors. But unfortunately, that's just a small percentage of patients. And so, what about people with locally advanced disease? I showed on those earlier things, even with T4 disease, the outcomes were poor. Sorry, with T2 disease, I apologize. With T2 disease, the outcomes were poor. So, how would this ever be something that's applied to, more bulky disease? And in the age of for locally advanced tumors, either a consolidation approach with chemoradiation followed by chemotherapy or an induction approach where the paradigm is flipped, we still have to check for response, right? How do we tell if folks still have disease? How do we, one, assess if they still have residual disease? And two, what do we do if it's equivocal? I was hoping that Dr. Cecchini was actually going to do a little bit I'm not going to talk about circulating tumor DNA here. I was hoping he would, but we're quite that coordinated. Okay, so talking about watch and wait, I'm just going to really briefly touch on it so we can keep moving. But really, first series published in 2004. And really, what the definition is tumor bed replaced by scar or normal mucosa on clinical and endoscopic exam. And I think that the most important thing is really the feel as over an endoscopic evaluation, but there are other adjuncts for this. Complete clinical response is not always predictive of pathologic complete response, and that's really the hard part. Just because it looks like something is either there or not does not always mean that it's the same thing. So, like anything in medicine, we always err on the side of sensitivity and not specificity. So we can certainly tolerate situations where we think that the person still has residual disease, but they've actually had a pathologic complete response, and we tell that on proctectomy. But the harder situation and the one that we really don't tolerate is when we think there's a complete clinical response, but there's not. And that's where we sort of have to talk about close surveillance. So, how do you tell? Um, there's a couple things that you can get to. Um, full, I put this a little bit out of order, but really your clinical assessment can entail MRI. I've got some features here that we do, but also digital rectal exam and full thickness local excision. So now again, we're getting all the way back to it. The problem is that it can be equivocal. So things like MRI, exam, and endoscopy, low sensitivity and specificity, depending on, again, a lot of observer bias or inner observer variability. But again, you can see here this complete response. Okay, I think we can all agree this person can be, well, not all. I think I would feel comfortable with a watch and wait approach for that. What about the, incomplete, obviously residual tumor? I think we can say, okay, going towards proctectomy or, doing TME. But what about this sort of in between person? Endoscopy can be challenging. The findings can be hard. There's a lot of false positives and false negatives. So then, talking about resection of the tumor bed or resection of residual disease, I think of this as a diagnostic tool at this point in time. There is ongoing studies to see if this is therapeutic, meaning are you debulking that last or getting rid of that last amount? But it has the ability really to upstage or adequately assess for residual disease, more so than maybe endoscopic biopsies or MRI. So, sorry, I went a little bit over time. But again, to get back to sort of the past and the present, I think that, yes, we've started with this very crude, though accurate, way of telling what's going on. We have this very complicated treatment paradigm for rectal cancer, and this doesn't even include metastatic disease, which can even be more. But I think ultimately, when we're thinking about these folks in this watch and wait setting, I still think there is a place for obviously the exam, but even things like transanal excision in that near complete response group. And with that, I'm open to any questions we may have. And thank you everyone for their time. I'm going to stop sharing.
Thank you, Haddon. Can you talk a little bit about the timing of surgery after radiation for rectal cancer and what the practice is at Yale?
Yeah, I think that's a great question. And I think you must have heard me arguing with Jeremy on Tumor Board. Yeah, so I think it's a really important point because we know that one of the major impacts on tumor regression is time between radiation and assessing response. And we know that the more time you wait, oftentimes you're going to see more response from radiation. And I kind of alluded to that a little earlier about induction. I talked about induction, total neoadjuvant therapy versus consolidation. And so if you look at like the Oprah trial, which we have there, a lot of people will say, well, if you look at and this is in the conclusions, I believe, if you look at the consolidation folks, so radiation, chemoradiation, Folfox, clinical response. If you look at that group, they have a higher rate of organ preservation and a higher rate of CCR compared to the induction folks, the chemo and then the radiation. And to me, I just think that's a little bit of comparing apples to oranges because in that first group, in the consolidation folks, the time between completion of radiation and assessing response is long. It's like about 3 months. And if you look at the induction TNT folks, it's like 8. It's like 1. So I think that can make it challenging. Our current practice here actually does depend. I think we do have a patient specific approach. Um, but currently, I usually try and assess response as far out as possible, with also the caveat that we tend to try and plan intervention about 10 weeks after completion of radiation. But there's also the legit. This is a great thing on paper. Okay, well, let's check at week 8 after 2 months after completion, and then if there's still disease, um,
I guess we've lost Haddon there. But as he mentioned, our general practice is to do the radiation at about the excuse me, do the surgery at about the 12-week mark after radiation. So I'll finish kind of his thoughts there. And typically doing the MRI 8, 9, 10 weeks after that radiation, as well as with flexible sigmoidoscopy around that time. Well, I want to thank everybody for joining this evening for our Yale continuing medical education for colorectal cancer for 2024-25. I hope you learned something. You can please feel free to email me at michael.cecchini@yale.edu or haddon.pantel@yale.edu. If you
I'm
wanted
back, Mike. Sorry,
to,
sorry.
I
I
wasn't sure if you're coming back, so
I had a I had a technical error. I'm sorry. So anyway, the point I was going to say is that's great, and that really makes the most sense. But also logistically, someone said, "Well, I have to plan. You're going to be planning an operation. I'm going to need to take time off of work. What about letting my family know? What about arranging for childcare or other things or transportation?" And so sometimes it can be logistically hard to do that. Um, I do, yeah. So those are sort of my thoughts.
absolutely.
All right,
All
sorry.
right. No, all good. Well, I kind of was in the beginning stages of the end um, of ending the CME. But again, thank you, Dr. Pantel. This was a fantastic presentation, fantastic discussion. Thank you to all our attendees for the questions. Please feel free to email either of us. Our names and emails are on the website, but it's pretty simple at Yale. It's first name dot last name at Yale.edu. We'd be happy to answer additional questions. Thank you so much. Have a great night, everyone.
Thanks.